Debbie Nadson, the project director for the VCSQI Support and Alignment Network 2.0. It is Tuesday, November 14th, and we're offering this webinar today to talk about data management and data submission as it's related to the Transforming Clinical Practice Initiative. Speaking today will be our Assistant Program Manager, Eddie Fonner. Eddie's the Executive Director of the Virginia Cardiac Services Quality Initiative, the home company of the SAN 2.0, and also serves as our Assistant Project Director for the government-funded SAN 2.0. He has an in-depth working knowledge of the clinical registry data and has worked with the Society of Thoracic Surgeons Adult Cardiac Surgery database for over 10 years. He will be our point man and your point man as it relates to the data management issues for VCSQI SAN 2.0 and your participation in it. So I'm going to turn it over to Eddie now. Go ahead, Eddie.
Thanks very much, Debbie, and thanks to everyone who's tuned in today on our conference line and on the webcast. As you mentioned, we are going to go over today some data submission and management requirements for the grant program and for our enrolled practices. Just wanted to start off with an intro slide showing the goals of the national effort for Transforming Clinical Practice Initiative, which is, in short, to support more than 140,000 clinicians in their transformation work and getting them into alternative payment models and into the higher levels of Medicare reimbursement, improving health outcomes for millions of patients, reducing unnecessary hospitalizations for 5 million plus patients, generating over $1 to $4 billion of savings for health systems, sustaining efficient care delivery by reducing unnecessary testing and procedures, and building an evidence base for practice transformation so that effective solutions can be scaled. And of this, all of our enrolled practices are really the leaders in this effort. But to produce this sort of documentation and help these transformation efforts, we really need data to build this evidence base. So that is really the goal of today's session, is to go over the data collection and capture requirements. We're asking from our enrolled practices a quarterly data upload for selected quality metrics, and we'll get in a little bit more in depth into which areas we're talking about there. We'll go over the measure definitions as well as mechanisms for data capture, and then provide just a brief summary of how we can track programs' performances and the corresponding quality improvements and estimated cost savings that go along with that level of quality data. And at any point, please feel free to stop me if anything is unclear. I know data can be a complex piece, so any questions or comments are most appreciated. In terms of defining our quality measures for the SAN 2.0, as of now, VCSQI has agreed to report 5 quality measures to CMS. This, however, can be subject to change depending on what is important to our enrolled practices. So if there's something that is near and dear to you, you've been working hard on, we would love to get that information to showcase your practices as a leader, again, nationwide. And we can then include those quality improvements and cost savings as part of the VCSQI's results to CMS. But as of right now, officially VCSQI is working on 5 quality areas. Most of these are with regards to cardiac surgery, where VCSQI's historical base has been, but a couple are the so-called cross-cutting metrics that can apply to pretty much everybody. So don't feel left out. And again, if there are other areas, please feel free to share those as well. But right now, the 5 measures are new onset of atrial fibrillation, intra or postoperative blood product transfusion, 30-day readmissions. Those are primarily the cardiac surgery measures, although readmissions is something that's pretty universal. We've just chosen to use a cardiac surgery denominator for the time being. The latter two, again, that apply to pretty much everybody are tobacco use and smoking cessation counseling and intervention, as well as hypertension control for patients with elevated blood pressure levels. So these are just an example, though, again, of a number of the metrics that can be picked from the CMS list of quality payment program metrics, which are available online, but we can report and measure really any definable metric. Anyone out there want to give examples of quality projects that you're working on currently? And just to give some background on the VCSQI metrics, reasons we've picked these 5 specifically. The first 3 have been areas that the VCSQI nonprofit group has worked on extensively over the years, especially AFib and blood products, and readmissions is a newer one that the group has focused on. VCSQI has developed consensus-based best practice protocols in these areas and has some pretty focused counseling and protocols that we can share to potentially help groups improve these rates. The latter 2, again, are the more cross-cutting areas, and feel like we can really make some broad impacts by focusing on these measures. But again, any and all data you feel is relevant to your quality and performance improvement is welcome here. Going on to how we can query the data, there's really a number of different ways. It depends on what sort of databases and measures you have access to at your local environment. I'll focus on 2 specific areas that are based on clinical registries, and then we can talk about how you might be able to do so in terms of other specialist areas or family medicine. In terms of cardiac surgery and cardiology, there are regular quarterly reports. If you're a part of a national registry such as STS or ACC, I produced just a sample of the STS reports on the right side of the screen. This shows how you can essentially go down and hand pick out the numbers that are already calculated for you. These are produced on a quarterly basis, and this specific instance shows new onset of AFib, which is, again, is one of the measures we're looking for. This sample site, just sample data, they made about a 6.5% improvements percentage-wise in terms of their 2016 data. So they would be able to claim, if that were after the enrollment in the SAN 2.0, that those are some cases of AFib prevented. We'll go into that methodology in a little bit. This is an example, though, just of the raw data and reports that you can pull information from. If you don't want to use your STS reports, or you don't have those available, you have some options, which would include querying the data on your local environment, whether it's via registry software or an EMR. We would have to work on these sort of on a site-by-site basis, just depending on what software you have available. However, there are a lot of options out there. What's most important, again, is to pick the measure, and then assuming you have the data available, we'll find a way to capture it, including some novel ways, even for sites who don't have EMRs, that we can explore via claims or an online data capture mechanism. So once you have your data, what do you do with it? Well, we're asking, again, these to be sent on a quarterly basis to my own personal account, but there are several different ways depending on your institution's security standards. So we have a couple secure options, and these would all be HIPAA compliant for data transfer. We're not asking for any PHI whatsoever, but again, if your hospital or institution's protocol necessitates that, we have these available. You can produce an encrypted zip file and send that and a password in 2 separate messages, and that would qualify. Or we also have a secure server setup and a Dropbox essentially to upload to. That image here is on the side. Essentially, it's a pretty easy form. You enter your name and your email, add a file or files, and you can send the package just by clicking that button. That'll go to a secure server that only I have access to and can download the data from there. Again, these are just options for secure data transfer. If there's no PHI and you're comfortable doing so, really it's perfectly safe to send via email. But again, wanted to put a number of options out there with regards to the database transfer. And again, we're looking for those quarterly. So once you have the data sent to us, essentially this is all going to be on the VCSQI server, and we are not reporting any specific site's information to CMS, but we're just reporting this data in aggregate as part of our quarterly reports. So CMS has asked us for this aggregate level quality data. So for all of our sites, we'll amalgamate all of the information and just say, okay, the VCSQI SAN 2.0's quality impact in AFib is X and readmission is Y. They've also asked us to come up with a number of cost savings that would be associated with these quality improvements. The TCPI, one of the affinity groups, has researched the associated costs with all of the common measures that have been asked of our group. For instance, about $22,000 for an unplanned hospital readmission. For these cases, and I'll show you the details here of how these estimates are produced. But for each of these areas, we are able to apply a cost savings estimation methodology. So this would go across these 8 TCPI common metrics, as well as any of the measures that VCSQI has previously published on in the cardiac surgery realm. This next slide shows just an example of the additive cost of complications work we've done in the past. Essentially, without going into too much detail, we have been able to use our linked clinical financial database to delineate costs for a number of the postoperative complications, as well as blood product transfusions. And for each of these areas, we can say, okay, if you've prevented a case of atrial fibrillation, you have saved your facility or practice an estimated $7,000. For renal failure, it's about $50,000, just based on the cost of hemodialysis and potential longer stay in the intensive care unit, etc. So these are just a basis for understanding how much savings you're generating to your health system. Here's a sample calculation that hopefully makes this a little bit more clear. In this instance, we'll establish a baseline rate and then produce an estimated savings in a study period. So the baseline rate in this period is Q2 2017. We'll say practice X had an AFib rate of 25%. After TCPI work and say implementing some of the components of the VCSQI protocol, practice X in Q3 reduced their rate to 20% of AFib for its 100 cases in that quarter. This overall reduction, 5% of 100, is about 5 cases of AFib prevented. And again, we can multiply that N of patients by the cost per complication of about $7,000, which would produce a cost savings of approximately $34,000 for that practice for 1 quarter. And this is, again, just for one measure. Across all measures and all practices, VCSQI is looking to generate significant cost savings in our TCPI work. But this is just to give an idea of the overall cost estimation and savings processes that will help your practice produce and essentially generate an ROI on the time you're spending working with the VCSQI SAN 2.0, while also demonstrating the efficacious results of our program. And that really is about it in terms of the high-level view of data collection, submission, and corresponding quality and cost tracking. Really, we're asking all sites to pick at least one measure that aligns with your practice's quality improvement goals. Send those data securely to our VCSQI team every quarter, and we will provide updates and reminders when those submissions are due, generally at the end of the quarter, and we have about a 30-day period to report on those. So at the end of the year and start of 2018, we'll send out those reminders and start our next reporting period. And as we and our great team with Debbie, Ivan, and others will provide coaching to help improve your quality of care, we'll track this quality improvement and corresponding cost savings over time, and hopefully see some great results together. And have a sort of an inspirational quote by Aristotle here: "We are what we do, repeatedly do. Excellence then is not an act, but a habit." And I felt like that was an appropriate metaphor for the mechanism of quality data capture. We're really trying to build some positive and productive habits here. So that has been our VCSQI experience, and I know CMS sometimes feels like it's the Great Dane in the room here, and we're a little smashed, but we're here to support you, and really happy to field any questions or comments you might have.
Eddie, thank you for an excellent overview. I wonder if I would push you just a little bit if a practice said, what have you found is the biggest bang for the buck? If we were to focus on one quality improvement that would show the most cost savings and lower the morbidities, perioperative morbidity the most, what would you think it might be?
It's a great question, Dr. Spear. Going back to some of our previously published literature, VCSQI had estimated the average cost of a postoperative transfusion at about $14,000 per case. And that is all inclusive just of the blood, not even with regards to any associated postoperative complication. So if you don't give blood on one case postoperatively, you could save up to $14,000. And that's one of the reasons why we selected that as a quality measure. And I think we could see some really huge cost savings associated with that area.
I think that as we've seen, and I recognize it's controversial, but because of the decrease of pulmonary insufficiency, renal failure, decrease in mortality, pulmonary insufficiency, renal failure, the real exponential from just the physical components of blood therapy. And so I would support your recommendations. I think that the findings with transfusion could far exceed just those numbers. So I would agree with your recommendation. I think whether or not amiodarone protocols or there's some others as well, but we know that that's the single reason for prolonged postoperative length of stay. So that may be a second recommendation.
That's a great point, Dr. Spear, and length of stay is another area that we did not even capture. So I think that would be another great proxy for looking at the corresponding savings for the quality areas we're measuring. Other questions or comments?
So Eddie, just to be clear for those who listen to the recording later, while we've been talking and you showed the measures that focus on cardiothoracic surgery, for those specialties in primary care who are listening and part of our project, they will be able to pick the measures for the most part that they intend to use. And then you'll have a discussion with them, or Ivan will, or I will, as to the data that we will need sent to us on a quarterly basis to monitor their progress. Correct?
Exactly, Debbie. And those can be one of the TCPI common measures. Those can be one of the quality payment program measures, or any other, well-defined metric that your practice is tracking. Yes, and we will work with you to help define, capture, and transfer that data from your practice to the SAN 2.0 Data Coordination Center.
Yeah, we're not looking to add more data collection burden to anyone. So measures that you're already using, perhaps through a registry where you've already collecting the data, and they can then send it to CMS for you, we will need it as well, but we're not looking to add to your data collection burden. You should be measuring and collecting data for those activities that you want to address with the patients that are cared for by your clinicians.
Eddie, will these slides be available to review?
Yes, sir. The slides and the recording will be available on the VCSQI website after this session.
Thank you.
And just to echo what Debbie said, this is, again, not meant to be an added burden to clinicians and administrators, but more meant as a tool to help develop effective data capture and reporting tools that would be in alignment with how you'll be reporting data to CMS via either MIPS or APMs going forward.
The only additional point I would make is slide 6. I think that a narrative for those that may come behind, and of course you already have it perhaps with the website, but that's a pretty confusing, or it may be not quite as clear to folks that may be doing it for the first time, particularly the drop and drag part. So a little further explanation may be of some benefit for those that don't have that primary experience.
Good point.
That's a great idea, Dr. Spear, and I was already working on a one-pager that would explain this data upload process. So you're right on the money there.
Also keep in mind, for those of you who are listening later, that Ivan Burkle is reaching out to all of you who are the designated point person to schedule phone calls with you. At some point, one of those phone calls may very well include Eddie, and you'll be able to see on screen how to submit the data and talk with him. And you can always call or email Eddie directly as well. And there's his email and phone number on the last slide. All right, well, thank you for those who are listening today, those who listen later. We're going to now stop the recording and have a good rest of your day.
Thank you very much.
Thank you.